So for the launch, the first webinar we start our training program with, and for this we invite from Karnataka state, representing the private sector here, Dr. Suman Rao, to say a few words and start with our first webinar. Dr. Suman Rao, over to you.
Thank you very much, Samiksha. Thank you, UNICEF, and thank you, NNF, for this brilliant venture where we are taking forward mentoring in 4 states to improve newborn survival, both survival as well as their outcomes, survive and thrive. And I'm really honored to be taking the first webinar for this. So first of all, I would say good afternoon. How are you? Bhagundara. Kenchi Achanti. I learned this from my Oriya secretary. And I do hope that at the end of this, maybe 6 months, we'll all learn each other's language too. So with that, Samiksha, if you permit, do you think I can get on with the webinar?
Sure, ma'am. And you can share your screen yourself. I made you a co-host.
Yeah.
If you have any problem, you can let me know.
Right. So the first webinar is on essential newborn care. And I must say that I don't think I'll be bringing anything new to you all at all, something that you all see every day, do every day, but just sort of brushing up the basics. That's what the first webinar is going to do. And today, the care of the normal newborn has various aspects. We will be talking about care at birth, but not about resuscitation. That is a separate webinar. We will be talking about identification of the at-risk newborn. Breastfeeding is a separate webinar. Temperature, maintenance, hypothermia is a separate webinar, and so is prevention of infections and newborn screening. But a little bit, we will be touching about immunization as well as discharge advice. So that's what I'm going to be speaking on for the next 20 minutes or so. And the first thing, whenever we are ready to welcome our most important guest, and unfortunately the most vulnerable guest also, that is our newborn, is to be prepared. And like my friend Rishikesh always says, failing to be prepared is preparing to fail. So we must be prepared in the labor room, and that means we need to be prepared with personnel. Every delivery should have a separate personnel for the baby, and that could be a nurse or a doctor. But this person should be well versed in initiating and taking care of the breathing of the baby and should be able to provide positive pressure ventilation. And such a person must be there in the labor room and not on call. In addition, we need to get everything ready to ensure that the 15% of the babies who require our help get the appropriate help. Most of the babies breathe and cry well at birth, but around 15% need some help. And very few percentage of babies actually need intubation and cardiac compression. But we need to be prepared all the time because this can come as a surprise. We should be going through the history of the mother, the charts, and ensure that we know, and we should have a brief huddle with our nurse and the doctors together to know what we expect and what we can do. But as far as resuscitation is concerned, that is going to be a separate webinar. What we need to focus on in every delivery is the 6 cleans for the safe delivery. We must look at clean hands. So just like a temple where we make sure that we wash our hands and feed and go, we need to clean our hands before we enter into the labor area. The labor room should be a very clean area, clean surface. The clothes should be clean and warm. The mother should be clean. The perineum should be clean. The cord tie that we use, and nowadays most people use cord clamps, that should be sterile, and the cord care also should be clean. These 5 cleans will reduce neonatal infections to a great extent. And the most important of this all is our hands. I know that most people, most patients says, they still believe that some of us doctors are God and say, doctor, everything is in your hands. Similarly, everything is indeed in our hands. We should ensure that our hands are clean and we don't transmit infections to the baby. So when a baby is born, 85 to 90% of the babies give a nice lusty cry at birth, And that's a delight to the mother, the obstetrician, the pediatrician. Probably the only time in life where we are so happy that someone is crying. And that is a normal newborn. And we, as health personnel, should be able to differentiate a normal, vigorous newborn versus another one like this who requires our support. And all of us are well versed with it. One important concept that I would like to say at this stage is about delayed cord clamping. Now, this is very important that we take at least a minute to clamp the cord, and we are in no hurry to do so. So this delayed cord clamping, where we wait for at least a minute, between 1 to 3 minutes, has shown that it reduces mortality, it prevents anemia in infancy, it improves the iron stores in the baby, and we know that iron is so important to the baby in infancy, even for brain growth. For the preterm, it stabilizes blood pressure, reduces the incidence of intravascular hemorrhages, and delayed cord clamping has also been shown to improve neurodevelopmental outcomes. So just a minute of the obstetrician time has a big role to play, and we as the neonatal care providers must ensure that all our babies get delayed cord clamping. But what about the babies who do not get delayed cord clamping because they need resuscitation? You need to cut the cord immediately and take the baby elsewhere. This is currently not in guidelines, but probably something that will come out. That is, we could consider milking the cord for all babies for more than 28 weeks if they need resuscitation, but not for lesser than 28 weeks. And in the near future, we are going to have neonatal resuscitation trolleys like this, which can be wheeled next to the mother's delivery cord, and we could do neonatal resuscitation on the intact cord. The next important thing I'm going to talk about is the skin-to-skin contact in the golden hour. And here we need to go back into nature. So often, I think many of you all would have seen animals delivering, and many times you don't even know how many puppies a baby has, because all of them are, well huddled below their mother. Our babies are also meant to do that. Zero separation should be the norm. And as soon as a baby is born, the baby should be dried, and then after 1 minute, the cord cut, and the baby should be placed on the mother's chest in skin-to-skin contact. This has been a very well-studied intervention, and we know that the benefits are numerous. It not only helps in maintaining temperature, but it also helps in the transition of the baby, stabilizes the glucose, reduces hypoglycemia, and it gives the very important right microbiome to the baby by colonizing the baby with the mother's bacteria. Breastfeeding, which we are still battling with, exclusive breastfeeding rates improves with skin-to-skin contact at birth. And not only that, the neurobehavior and development, even at 10 years, have been shown to be far better with skin-to-skin contact. So this is another intervention which has been there in the recommendation for a long time, but its implementation is still an issue, and therefore we need to work towards it. Taking the birth weight is important, but it can be delayed for an hour after skin-to-skin contact. We have seen from our mentoring visits and the different studies we have done in the community that birth weight is something where the error can be to an extent of 30%. In fact, there's a lot of rounding and heaping around 2.5 kgs. In one study, they showed that 30% of the birth weights were recorded as 2.5 kgs. So digital weighing machine does help, but the important thing is to do it very diligently, ensure we have a naked baby, ensure that the weighing machine is cleaned and it is covered so that the baby doesn't become hypothermic, and then take the weight and document it correctly. The other intervention is vitamin K, and the current NSSK guidelines talks about vitamin K1 or the phytomelodione, which is better than the synthetic vitamin K. And we need to give 1 milligrams intramuscularly on the anterior lateral aspect of the thigh for all babies more than 1,000 grams. And for babies less than 1,000 grams, it is 0.5 milligrams. And this is important to prevent vitamin K deficiency bleeding or the hemorrhagic disease of the newborn. The next big thing that we have is to ensure that we do a complete rapid examination to rule out major congenital malformations. And we do get a lot of clues right there in the labor room, like you see here. A baby who has a lot of saliva coming out could be suffering from tracheoesophageal fistula. You could have a clue like polyhydramnios. Similarly, a scaphoid abdomen, heart sounds heard more on the right side, suggests congenital diaphragmatic hernia. Here we have a congenital adrenal hyperplasia baby with ambiguous genitalia, and this becomes a social emergency because we know that we have to talk about the sex of the baby right at birth. This is a baby with eye defects, in fact, had severe microphthalmos. Cleft palate is something that we have to watch out for because it can be isolated even without a cleft lip. Look at the back of the baby for any such thing, and similarly, do an orifice count not to miss out in perforatanus. The 4 areas I always look out for are the eyes, the palate, the back, and the genitalia, because these are areas that are easily missed. In addition to this, we do get some clues which by themselves are not a major malformation, but we need to look out for other major malformations here. For example, if you have a simian crease, if you have a single umbilical artery, a preauricular tag, or an absence of the depressor anguli oris muscle, we need to screen and make sure that there are no other major malformation. And all this is done right in the labor room. In fact, most of the malformations are picked up in the labor room by a diligent nurse and by a diligent doctor. We also have to ensure that we now decide, is this a well newborn who can be sent to the mother's side, or is this a baby at risk who needs to be sent to the NBSU or the SNCU because this baby needs monitoring? So all babies with a birth weight of less than 1.8 kgs, gestational age less than 34 weeks, who are asphyxiated, have difficulty in breathing, or any major malformation, definitely needs to go to the SNCU for care as well as for monitoring. But even those babies who are shifted to the mother's side, please do remember they're just having a transition from a very safe in utero environment to outside. And therefore, these babies need to be monitored every 15 minutes to ensure that they make this transition well. And we need to look at breathing, temperature, color, and document this in the case paper to make sure that these babies who are well and cry well at birth continue to be well. The other job we have right at care at birth is to communicate with the family. Yes, if the birth companion is already there, then it's so much easier, but we need to communicate, show the sex, ensure that we tell the family about the mother's and the baby's condition. Then we now come to care beyond birth. It would be good to transfer babies from the labor room to the postnatal wards in skin-to-skin contact. And one major area that we need to help with is breastfeeding. These babies need to be observed twice daily by the SNCU medical officer or a pediatric doctor or even the nurse, and we need to document the condition of the baby. Very, very important are 2 things. Keeping the baby warm at all times, even in summer. Please remember that newborn babies, even good weight newborn babies, can rapidly slip into hypothermia. So keeping them warm with an additional layer of clothing is good. And then we also need to ensure that we support them for adequate breastfeeding. Breastfeeding is natural, yes, but mothers need support. We need to inquire about the passage of urine in stools. Babies should pass the first stools within the first 24 hours. And the first urine, most of them pass within the first 24 hours, that is 97%, but a small fraction may pass it on day 2 too. The other new problem which can come up is jaundice. And again, in your twice daily monitoring, look out for any new danger signs. So a well baby is one who has a normal temperature, is breathing easily, is very active, moves arms and legs very well. And these are things which should be documented in the case file. Temperature maintenance is important. And it's so important that we have a separate webinar for you, but we do have videos on how to swaddle. And it's important that the family learns how to swaddle. With the dissolution of the joint family, the nuclear families, many of them are even hesitant to even hold the baby. And we need to encourage the father to do this, take care and support the mother. And swaddling is something that we always try to teach the family member and the father. Then we come to the cord care. It is really great that we have overcome neonatal tetanus majorly. But it's still important that we focus on cord care. When we are cutting the cord, it's just about 3-finger distance from the base so that it's not so long that it is dangling near the genitalia. Tie and put a cord clamp and keep observing it to see if there is any bleeding. And dry cord care without applying anything is the norm, and always make sure that the cord is outside the diaper, and generally it falls off in 4 to 10 days, maybe with a drop of pus or blood at the end, and this is something that you need to communicate to the family to watch out for. The skin of the baby, remember, is sterile. It's covered by vernix caseosa, and vernix caseosa is good for the baby. We should not be in a hurry to remove it. And bathing should be delayed as long as possible. And in fact, we do not bathe our babies in the hospital stay at all. Even on day 1, when we bathe the baby, the risk of hypothermia is there. And please, if you bathe the baby, ensure that you rapidly do it with lukewarm water, feed the baby, dry the baby, cover the baby, and ensure that he doesn't go into hypothermia. Any soiled area can be cleaned with lukewarm water, and the skin of the baby doesn't need any other ointments or creams. Eye care, there is no routine eye care which is required, no routine cleaning. Avoid kajal, but sometimes babies do have sticky eyes and you may have to clean it. Remember to do it from medial to lateral side with normal saline or distilled water. And many babies have a lot of watering of the eyes. And this may be because of partial obstruction of the nasolacrimal duct. So therefore, an eye massage by squeezing on your lacrimal sac downwards around 10 times during each feed is going to help overcome this. And this is a problem generally which resolves on its own by around 6 months. Breastfeeding support is probably the most important job we do during care of the baby after birth, and most mothers require a lot of support to ensure that they successfully establish breastfeeding. Again, that's going to be a separate seminar, a webinar, and some of the things that we see routinely on rounds, which the family gets worried about, and we need to proactively tell them that this is fine so that they don't go and do any traditional medicines which may be harmful. Things like the Mongolian spots, the erythema toxicum, which can come out and worry the family, dry skin, melia, neonatal acne. There are some very, very sharp mothers who are so focused that they even talk about the Epstein's pearls. Mastitis neonatorum is something that you need to tell them, please don't rub the breast. The breast look big. It is fine. Do not do it because otherwise it will result in infection. Again, pseudomenses is something very common, and it would be good to give anticipatory advice to the family. Routinely, the babies lose weight. The normal weight loss may be up to 10% in the first 3 to 5 days, and they regain weight by around 7 to 10 days. Definitely by 15 days, they should gain weight. But yes, particularly in primary mothers, excessive weight loss can be a problem, and this can aggravate the physiological jaundice, result in hypoglycemia, and sometimes even dangerously hyponatremia. So if you think by around 48 hours, the baby is not doing well, check the weight to ensure that the baby's weight loss is not too much. And such families need extra support for supporting the breastfeeding. Immunization is part of normal newborn care, where we give BCG, 0.05 ml intradermal, OPV, hepatitis B vaccine, and nowadays it's encouraged to do all this right in the labor room. Whatever said, it should definitely be done by the time of discharge, and all babies should get immunized and then get discharged. Counseling and education is a very important part of postnatal care. The nurse needs to give anticipatory advice. I do believe that both combined group counseling and individual counseling is required, and it's always good to include the entire family for such counseling. We have a lot of traditional practices in India, and this differs from region to region. And we need to talk about the harmful practices and advise them not to instill oil in the nose and ears, not to apply anything to the cord, not to apply kajal, give prelacteal feeds, give honey and such things. But yes, yes, some traditional practices like massage are beneficial, And they have been shown, even by evidence, that it can improve neurobehavior and even neurodevelopment. So this is something that we should encourage. Many things that we need to keep talking to the family that these are normal because these are things that can vary. Pussetting or regurgitation or vomiting includes increased stool frequency is something which is common. We need to give them anticipatory advice. Jaundice, but at the same time, please do remember that the palms and soles should be free of jaundice, otherwise it's a danger sign. Hiccups and sneezing and yawning are normal. It is not a sign of a cold. And as babies grow, they're going to increase their crying. And this is again a normal phenomenon. By around 6 weeks, babies may cry, normally even up to 3 hours per day, and these should be told to the family so that they do not give unnecessary treatment. And many of them do feel that anytime a baby is crying, the baby requires milk, and this may lead to mothers thinking they have inadequate milk, so we need to give a lot of support during these times. Every family should know about the danger signs before discharge so that they can bring back the baby. Particularly lethargy, not feeling well, convulsions are the danger signs which usually show that the baby has some infection, but others like temperature fluctuations, distress, cyanosis, bleeding, abdominal distension, vomiting, and diarrhea are also the other danger signs for which the family should be asked to seek care. So here you see a baby with retractions. Please use the local language when you talk about these things like cyanosis and yellow staining of the palms and soles. Discharge should be delayed even for a normal baby beyond 48 hours, and this baby should be free from any illness and any significant jaundice. Routine screening for jaundice is currently not a norm, but is possibly going to come into routine screening quickly. Breastfeeding should be well established. Immunization should be done. And whatever newborn screening you have in your setup must be done before the baby is discharged. The mother should be confident. She must know the mother-child protection card very well, and this should be explained to her. And she should know when and how to seek for help and when she should come for follow-up. So that was my short webinar, a quick brushing of whatever you all already know. And I hope it was useful. Thank you very much. Over to you, Samiksha.